so difficult to do. It was common that you would just accidentally stick the needle right into the cytoplasm, which is why you do ICSI. And the discovery was that it works just as well and it's so much simpler. So ICSI was really kind of born a little bit by accident, um, but found to be extremely important because poor fertilization, no fertilization, typically related to the male, is very common in IVF, and it revolutionized how we do. So you can have a very, very abnormal, and I would say that I always say it's three parameters that matter. It's the count, the motility, and the morphology. They're all very important. Again, if you know your lab, like I know from RMA, 7 years there, almost everything comes back abnormal morphology. And I won't get into the details of why that may or may not be a problem. But if the count, you typically have a real problem, the count, the motility, and the morphology will all be abnormal. And when you see those men, it's called oligosteatoteratospermia. You'll see OATS, OATS, right? When men have OATS, they probably really do have a male factor. And so again, of the men we see in general in our subspecialty, and that would be true most places because of the way we in our field grade sperm, according to a strict WHO standard, probably at least 50%, some programs probably as high as 60 to 70% of the specimens will be abnormal, and the males will be told they have a male factor. And the problem with doing that is that everybody's looking at now him as if he's the problem, when it may be very mild or not even important clinically. But everybody wants a diagnosis. They don't like to be called idiopathic. We don't know what's wrong with you in fertility. But of that 50% of abnormal specimens, probably only about 5 to 10% of them have OATS, really have OATS on repetitive sampling, or something like this, a very specific single compartment defect. And then the only other thing I want to mention, since I see the clock and I just will finish out with this case, is what I think is an over-diagnosis and over emphasis on varicoceles. Okay. I mean, varicoceles are extremely common in men. Whether or not they really cause infertility has been debated forever. I've certainly seen anecdotally, and there's certainly observational studies that suggest that symptomatic, large, usually left-sided varicoceles, when ligated, improve fertility potential. But the problem with those studies are that you typically study design, and it's really hard to pinpoint whether it's an absolute or not. So in this man, I think because it was talked about briefly, I think it's just an incidental finding. I don't think ligating his varicocele would do anything for him. I think to your point, though, about, and I'm glad you pointed it out, because a lot of people don't know the difference in primary and secondary hypogonadism. But it is odd that his gonadotropins weren't elevated when he had a low testosterone. And that was on several samples, I believe. So it sort of implies that he has a secondary hypogonadism due to perhaps a pituitary issue. The reason for them giving him clomiphene, basically, a SERM on a low dose daily basis, it does increase gonadotropin pulsatility, right? And so it's possible, especially if it's necrospermia, that by correcting his gonadotropins or even with a shot of HMG, like the old Pergonal shots, you can increase testosterone, you can increase spermatogenesis or enhance it, and suddenly you might start to see some development of viable sperm.
With only 60 seconds left, you said that the brother also has sperm dysfunction. Is there a genetic sperm dysfunction inherited by males? Or was that just random?
You asking me or asking Vish?
You. Now
Oh,
there's only 30 seconds left.
well, that's easy. The answer is yes, there is, and a variety of types. And now with whole genome sequencing, there's quite a few mutations that both on the X and the Y chromosome that dictate normal morphology, normal sperm behavior, so to speak. So yeah, it could be, and it can be variable in its expression, right? So you can have in one man, complete absence of motility, which can be mapped again to a chromosome, whereas brother might have like probably compromised, but not global total, or it could be a spontaneous mutation too, right? So yeah, the answer is yes, and that could be important. And two, if you do these procedures, that chromosome can be passed on to this, the males that you produce. So you might want to know that if it's mappable.
All right. Thank you so much. Thank you, Vaish. Excellent job. But it is time now that we transition to grand rounds. So in just a minute, I'm going to ask Dr. Stevenson to introduce our grand round speaker. But in the meantime, all of our normal announcements regarding attendance are in place this morning. The most important one being if your name is not displayed clearly in the attendance list, please email your attendance to Beth or Michelle or I, or if you're a student, to Millie. All right, Dr. Stevenson, are you ready to introduce our speaker?
Yes, I'm ready. So it's my pleasure to introduce Dr. Ko. I met her, I think 2 years ago now at the Winter SGO, and I listened to her talk about disparities in clinical trials. So I'll tell you a little bit about her. And I think some of us know her, like Dr. Patenkar. So she's an associate professor at the University of Pennsylvania, Perelman School of Medicine in the Division of GYN Oncology. She trained at the Brigham and fellowship at UNC. She's extensively published, and she uses her research and clinical expertise to improve access to delivery of care and healthcare disparities in patient outcomes. She received funding from the American Society of Clinical Oncologists, the American Cancer Society, and the NIH. She serves as the Pennsylvania Hospital Abramson Cancer Center Medical Director and UPenn Leonard Davis Institute of Health Economics Senior Scholar, as well as faculty of the Penn Center for Cancer Care Innovation and member of the Abramson Cancer Control Program. She directs the UPenn Gynonc Population Science Research Programs. She mentors numerous trainees in research and GYN oncology, and serves as the Associate Program Director for the UPenn Gynonc Fellowship. She also serves as a member of the editorial board for the Journal of Obstetrics and Gynecology and GYN Oncology Reports, and she serves on the SGO Board of Directors and served as the chair of the SGO Health Policy and Socioeconomic Committee, where she led many efforts to advocate and implement policies to improve gynecologic cancer care. So I think Dr. Ko knows that, clinical trials are a labor of love. And so we're very excited to hear about her take on disparities in clinical trials and potential challenges and solutions. So with that, welcome, Dr. Ko, and I'll turn it over to you.
Great. Thank you so much, Dr. Stevenson. It's a great pleasure to be here this morning, and great to, see some former fellows, colleagues, now faculty, still nearby. So without further ado, I will get my slides up here. All right. How does it look? It looks okay.
Yes,
Looks
it looks
perfect.
good.
Perfect. Great. Thank you so much. So for today, I want to focus on disparities in clinical trials and potential challenges and solutions. There we go. A couple disclosures listed here, and no unlabeled investigational use of drugs will be discussed. So for our objectives, there are really three main objectives for today. We want to first review disparities in clinical trials enrollment, including patient, provider, health systems, and policy-associated factors. Second, we want to review how we can implement practical strategies to increase representation of all populations in clinical trials. And third, identify methods to engage in advocacy to improve clinical trial opportunities. So as we know, clinical trials in general are an opportunity. They should be standard of care when other treatments have not worked or have failed. That being said, I want to emphasize that clinical trials are not the last line. Frequently, especially nowadays, clinical trials may be great opportunities as first-line treatment for cancer diagnoses or right after surgery. So they are absolutely not the last line of defense for patients. Clinical trials are certainly endorsed by our major societal medical organizations, for example, SGO, the NCCN National Cancer Centers Network, and of course, ASCO, American Society of Clinical Oncologists. And in general, patients by default are eligible unless they're excluded by scientific rationale. That being said, patients may perceive clinical trials as sort of the end of life, last step that they may hear about. And I think that is something that we want to really think about, and that we want to actually change how we promote clinical trials, how we talk about them, and how we, educate patients about clinical trials. So there are plenty of sources to look up in terms of clinical trials. NIH, well, NIH maybe had more information in the past than present day. That being said, many, many sources available, American Cancer Society, et cetera, for general information on trials. Now, what do we know about enrollment? There definitely is disparities in clinical trial enrollment with various patient populations, and there has been historically low trial participation by minorities. We can look at this many different ways. If you just take census data of the US, based on census population data from 2020 versus FDA trial participant enrollments, and you look by different racial populations, you'll see there are disparities. For example, in the US, 14% are Black, but if FDA enrolled trialies, only 8% are Black. You look at Hispanics, 18% of the census population versus 11% in FDA trials. Asians and whites, however, there isn't as great of a difference, 7% versus 6% and 76% versus 75%, as you can see here. Now let's take a deeper dive into GYN cancer trial enrollment. And there are a couple studies published back in 2015 and 2020 that highlighted, basically the distribution of participants. The first study in 2015 by Dr. Scalisi et al. Looked at 170 studies. They were within the GOG, so that's a gynecologic oncology group, and that was what our prior national consortia network of gyn-onc clinical trials was run through the GOG. And these trials are over almost 20 years time worth of trials. Overall, they actually saw that there was a steady decline in the proportion of Black patients enrolled over time. And the observed Black enrollment was 15-fold lower than expected for ovary cancer patients, 10-fold lower for endometrial, 4.5-fold lower for cervix. So that's really, I think concerning. And if we look, for example, at phase 1 gyn-onc clinical trials, this was a publication in 2020 titled 3 Decades of Inequity. Here they gathered 357 published phase 1 studies within all those, 5% were Black. And, Black participant enrollment decreased over time as well. Enrollment of Blacks was less than expected for ovarian, endometrial, and cervical cancer. So I think this data is quite telling, who's actually enrolled onto our big national clinical trials. Now, let's look at some more contemporary data. So here, my fellow at the time and colleagues here at Penn, we looked at the Flatiron database. So this is nearly 20 years worth of US nationwide real-world data. And instead of looking at who's actually enrolled in clinical trials, we took entirety of patients who had ovarian cancer and endometrial cancer in this database. So when we looked specifically at endometrial cancer patients who had advanced or recurrent endometrial cancer, over 4,600 patients were characterized in this database. Only 4% were ever enrolled in a clinical drug trial. And then there were differences. Blacks were less likely to enroll than whites, even after adjusting for BMI stage and functional status. And while they accounted for 14% of the entire endometrial cancer population, but only 10% of the clinical trial population. And when we looked at ovarian cancer patients specifically within this very large real-world database, and this was a separate publication, again, from 2011 to 2021, so a more contemporary cohort of patients, over 7,000, only about 5,000 of them were ever enrolled in a clinical trial. And what we found that there were differences again in who were enrolled. So for minority populations, there was a lesser enrollment by Hispanics. And furthermore, in general, overall, Medicaid patients were 51% less likely to enroll compared to privately insured, and Medicare patients were 32% less likely to enroll compared to privately insured patients. And you can see that highlighted here in this forest plot. So, you might say, okay, fine, there are definitely disparities. We looked at it from different viewpoints. FDA trials, gyn-onc trials, and now even just, looking at real world data, there are definitely disparities. Now, what if you were to ask, well, why is that? I was thinking, well, maybe it's because there just aren't trials located in areas that patients can get to. You know, are there geographic disparities across the entire country of where our clinical trials are opened? And so I had this hunch, and so we conducted another study where we were looking at actually geographical distribution across the entirety of the US. So in this study that was recently published in JAMA Open Network, we actually searched clinicaltrials.gov. And this was over 25 years time worth of clinicaltrials.gov trials that were registered. And we initially found 5,500 plus clinicaltrials.gov trials that were related to GY and cancer. And then we literally manually filtered it down to invasive cancer trials. We end up with 1,500 plus. And when we looked more closely at what type of trials these were, what diseases they were for, and then where are they located, and further looked at what are the relationships to the census population, racial distributions, and also social vulnerability indices, we found that, not surprisingly, there were more gynecologic oncology trials located in areas where there were higher proportion of white patients compared to minority patients. That's what you see in the graph on the left A. And then we also saw that there was a relationship as well, where in areas of higher social vulnerability, which is the graph B there, demonstrated on the y-axis, there were actually fewer trials available. So not necessarily surprising, but I think it was a way that we actually wanted to actually demonstrate this and map it out. And here, this was also part of the paper, we basically looked at different states, different regions of the country, and illustrated here on figure A versus B versus C. A is demonstrating states where there are greater proportions of minority populations, and then looking at what is the number of trials per 100,000 persons in that state. So you can see the red to the green distribution. Red means there are fewer trials, only 1 to 2 per 100,000. And as you go to the orange, yellow, green, there are more trials. And as you can see in states with more minority patients, there are actually fewer trials per the patient population. And when there are states with lesser minorities and a greater proportion of whites, there are actually more trials available. So again, it's not necessarily surprising, but it is illustrating what we thought was reality, that where trials are located is also related to potentially why certain patient populations enroll in them. So how do we actually move the needle and think about how do we increase enrollment wherever we might be? And how do we decrease the burden on patients when they potentially would like to enroll in trials? And how do we customize trial access and design? So here we want to dive a little deeper and say, well, why patients do not participate in clinical trials? What are the barriers? And if you look on the left side, they can be categorized into, for example, structural. Are the trials available? We just saw that in certain areas, trials are just not available. Are the patients clinically eligible? So this can be another barrier where if the criteria is so strict, it's going to be hard to get patients on trials. Then are there barriers at the physician level? Are physicians too busy, just don't know about trials, aren't motivated to offer them because it takes more time and effort? And then lastly, patient decision. Again, many factors involved in patient decision, whether to enroll or not. So if you say, well, what are those patient decision factors? Well, this was a really interesting study conducted by Unger et al. And you'll see on the bar graph on the right, they actually surveyed over 5,000 patients. And of those, about 482 did not participate on a trial. And then they dove deeper and said, why didn't they participate? They asked patients, why didn't you want to participate on a trial? And these were the answers. They didn't like the randomized treatment. They didn't like the research protocol. They didn't want treatment. They thought the treatment might just have bad side effects. They thought there was no personal benefit to the treatment, that the treatment wasn't right. The doctor just didn't convince me. It's just too much time and effort. The nurse didn't convince me. My friends or family were just against trials. Potentially would just delay my treatment. It's too hard to get to the clinic, for the trial visits. How do I pay for these extra visits and parking? The family burden is just too much. I just don't have enough info about trials. The questions about the consent form are just confusing. Maybe it's just going to be worse treatment. My doctor was just against it. There's no long-term benefit potentially that I see. It wouldn't advance science. I'm not sure about that. You know, did not trust staff, did not trust the quality of the trial, and the consent is just confusing. So I don't think these are necessarily surprising, but I think it is really, you know, telling when you're able to delineate these patient concerns. Now, as we spoke about, addressing clinical trial barriers takes many steps, and we can think about, you know, different barriers, whether it's at the health system level, at the provider level, the patient level. So from a health system standpoint, we have to think about what trials are we making available to our patients? You know, what's our screening and matching navigational effort? You know, is there translational barriers? Is there just bias against various populations within a community? Is there just lack of outreach to the community? What's the effort to engage and educate? And are there just practical barriers like insurance, other policies that make it difficult? And do we have enough funds to start up a trials and provide all the resources we want to provide to be able to run them? From a provider standpoint, you know, I think there are many barriers as well. It's hard to know all about all the trials that could be available and keep up to date with all the eligibility criteria. There are time constraints. We're just trying to get through our clinic. You know, is the research team diverse, and do they have, you know, maybe different cultural awareness and methods of communication? And is there just unconscious bias when we say, that patient probably wouldn't be interested, that patient probably wouldn't be compliant? Are we already just automatically eliminating patients? And then from the patient standpoint, are they aware of what a clinical trial even is? Do they have beliefs and attitudes that would prevent their interest in trial? Are there language issues, health insurance issues, just family work, financial out-of-pocket costs and concerns, transportation, and just plain mistrust? And that we know is a real thing, and for reasons because of historically various, studies that have occurred and concerns there. So putting this all together, then how do we address it? And why should we bother? So coming from all levels, if we look a few years back, even the FDA had said, okay, there is imperative to improve diversity in clinical trials, and there was a mandate. Ensure that drugs work and are safe for all those who may use them. And approximately 20% of drugs have different effects depending on a patient's race. So can we generalize results to different populations if these populations were not enrolled on the trials? There, as we think about this, it's pretty obvious. Trial populations should reflect real world populations who might receive any particular therapy. And so the FDA in years past had put out various guidance documents here, 2017, 2020, 2022, as they're highlighted here, that helped instruct on collection of race and ethnicity data in clinical trials and enhancing diversity in populations with regards to eligibility criteria, enrollment practice, and trial designs for industry, and then diversity plans to improve enrollment of underrepresented populations in clinical trials. So all of these documents were were certainly available for reference in years prior, and were very, very actually informative to read through and actually somewhat dense. And then in 2023, the FDA actually required that for certain trials, there must be diversity reporting. And this came through the Consolidated Appropriations Act, through the Food and Drug Omnibus Reform Act, and it required diversity plans for all device studies and phase 3 drug studies. So you can see that here. This was certainly a document, and what they required was reporting on sex, gender identity, age, socioeconomic status, disability, pregnancy status, lactation status, and even comorbidities. And so what did you have to do if you were running a trial? You had to describe the composition of the proposed study population in terms of sex or gender, racial, ethnic groups, and provide a rationale for the proposed selections. Any exclusions based on sex or gender, race, or ethnicity must include a rationale and justification based on scientific or ethical basis. And NIH recipients must collect and annually report information as stated. And for phase 3 trials, they must address plans for valid analysis of group differences on basis of sex, gender, race, and ethnicity, unless there is clear evidence that such differences are unlikely to be seen. You have to provide this an annual progress report for each primary outcome, and you have to update it in the clinicaltrials.gov database. So if you were designing a clinical trial, if you're responsible for a clinical trial, you might say, well, what does a race and ethnic diversity plan look like? Because you have to write this into your protocol. So here we go. One, you want to provide an overview of the disease, describe demographics of minority with disease, and what is the evidence of disease or treatment varying by race and ethnicity and other populations. You also want to think about scope of program. So in terms of study design population, what are the eligibility criteria, endpoints, geographic locations, and impact on diversity? And what's the pharmacologic data, different effects based on race and ethnicity? And then regarding goals of minority enrollment, you have to explain how you're going to try to enroll patients of different populations. And with that action plan to enroll, retain, describe the different location sites that you're going to recruit and how you're going to provide access. What are the strategies for community engagement and reducing patient burden? And then tracking, how are you going to track your enrollment and your progress? So as we think about how we create this diversity plan, there are actually sort of tips and tricks, for example, that the FDA has provided through their guidance documents. And these are highlighting those tips and tricks. Number one, ensure eligibility allows the broadest inclusion criteria. So avoid being really restrictive, avoid what we call carryover criteria. So if you had a phase 1 or phase 2 study that were relatively strict eligibility, don't just copy it over into your phase 3 trial. Think about, is it truly necessary? Can you broaden the eligibility in terms of comorbidities, HIV status, so on and so forth. Second point, enroll patients to reflect real-world clinically relevant treatment populations and evaluate, genetics, metabolism, clearance, environmental exposures that are associated. 3, use adaptive clinical trial design. So here you really want to involve your biostatistician expert to help you, design a clinical trial and help you think about enrollment so that you're going to be most efficient. You want to basically figure out how you can enroll the least number of patients to answer the question that you want to answer in the populations you need to address. And so at different phases of a trial, you could really sort of modify the type of trial design. So it's called adaptive clinical trial design. And then 4, include enrichment enrollment. So we think of prognostic enrichment, increase patients more likely to reach the study endpoint versus predictive enrichment, where you're trying to increase patients more likely to respond to the intervention. And then 5, reduce unnecessary visits and burden, thinking about telemedicine, other innovative strategies. Additional points, make it easy and accessible. So have as much remote medical care as possible, labs, home visits, satellite sites. Use electronic informed consent. So they don't have to come in person to just consent, right? Like get it through your IRB that you're going to be able to do electronic telemed consents. 3, explore agreements to facilitate exchange of medical records. 4, explore agreements to share results with participants. Participants don't want to just be, enrolled, but never understand what the results and the return might be to them or their community. 5, recruit with informed geographic practices. Think about where your patients are coming from, what areas you want to recruit from. 6, implement exclusive strategies for public outreach. 7, foster community engagement. 8, provide information in multiple languages that are culturally attuned. So try to, have, get IRB approval for translating as many of the consent forms or short forms documents as possible. And 9, inform candidates of financial reimbursement for expenses. Be transparent. And if there are resources to help them through those barriers, then provide those. So what did we do at Penn? Trying to bring it down to our local community and our institution. And here we thought about it from different angles, and this is definitely still a continual work in progress. It's been several years worth of developing this program, and these are some of the points to share. From a health system standpoint, Is there ability to have some type of navigational process? And is that a clinical trials navigator? Is that a new patient navigator? Is that your clinical trials unit serving that purpose? Think about our trials and staff, our clinical research unit staff reflecting demographics of patient population, because yes, there is an ability to communicate and form sort of better relationships when the staff do reflect what your local population may look like. Identify provider bias, again, really trying to remind ourselves, don't just assume that they wouldn't be interested. Don't just assume a patient would not be compliant or qualify. And think about how can we screen in a more efficient structure. I'll talk about this in the slides to come. From patient perspective, can we provide supportive care services and address their social determinant of health needs and barriers? Yes, it takes a bit of effort and reduce burden on patient family. And lastly, community outreach. How do we address the mistrust and misinformation? How do we improve communication and just pure talking about clinical trials? And we'll talk about that. So starting here, we thought about, well, how are we identifying our patients and referring them through clinical trials? So this was a study that was initiated in 2021, 2022 by one of residents and fellows. And what we did is we looked at our referral processes, and what we thought was great at the time ended up being not that great. We thought, well, we have this tumor board. It's called a treatment planning conference, TPC conference, that we run every week. And these are dedicated to patients that really progressed on their prior chemo. So they need a new line, they maybe need a new trial opportunity. We call it basically a chemo conference. So we thought this is a great forum. If we can funnel all the patients that are needing a new line of therapy to this conference, talk about them, then we can think about and which patients could be eligible for clinical trials. So after taking a year's worth of lists of patients, over 200 patients that were talked about at TPC, we actually looked closer and said, what happened? How many did we actually refer? 112. How many were actually eligible as we whittled down through this list? 16. And ultimately 10 patients enrolled. So this, at the end of the day, we thought was a great process, but in reality wasn't that great of a process. Then where did all our clinical trial patients actually come from? They were more just in the door from the alternate methods. And what it reality was a lot of the patients were sort of identified either by a med-oncs, we had a few key GYN med-oncs, or defined by a gyn-onc. They sort of just found the trials that they were directly looking for that were potentially eligible for, and fast-tracked them and said, you're coming here because you want this trial, and that's where the majority of our patients came from that were trial participants. What do we learn from this process? Well, the process of our TPC meeting was not effective. When you just sort of are blindsided and hear about a patient, for the first time on that conference, you can't quickly think about what trials are available when we have a portfolio of 30 trials on our list. You just can't efficiently think off the top of your head which ones they're eligible for. Just too complicated. So we realized we got to integrate this screening process earlier. And now we've actually instituted what we call a pre-screen process. So all the patients that want to be discussed at TPC are actually, the names are sent into a list the week before. Our clinical trials unit personnel, there's dedicated 1 or 2 people actually take that list and they do a pre-screen. They're the ones that already know of our 30 trial portfolio, what the eligibility criteria generally are for these trials. They can efficiently fly through it, do a pre-screen, do a quick chart review, and say, hey, for this entire list, these patients would be eligible for XYZ trial. Then when we actually discuss them at TPC, we can dive in greater detail. The providers are already informed, the fellows are informed, and we can actually more efficiently talk to the patient and think about, is it a realistic option? Also socializing across the health systems. We have 4 cancer centers. We have med-oncs scattered at all of them, as well as gyn-oncs. And we really got to, upstream, make the trial information available rather than this very downstream approach. And again, really engaging our CRU is key. So we looked at a few other things here. For example, where do our patients come from? What cancers do they have? And this was also sort of enlightening as well. We took a couple years worth of patients and we looked at those who actually enrolled on our trials. We looked at those who are potentially eligible and needed a new line of therapy through our TPC conference. And it was over 200 patients. And these are patients you would think, well, they're advanced, they're recurrent. These are the folks that we want to really highlight. but where are they coming from? And this again was really enlightening when we looked at sort of racial distributions. In fact, the majority of all our Black patients are actually coming from within our city, versus the majority, vast majority of our white patients are actually coming from outside of our city in our tri-state area. Not necessarily surprising, but still enlightening. And then when we think about what type of cancers they had, if you look at this graph, the very bottom row showed that the majority of our Black patients in our whole practice, they're within our city, and they actually had only about a third were ovary, but more than a third in the orange were uterine cancer. A fair bit were cervical cancer, and then there was some other cancers. Whereas if you look at the row second from the top, the white patients, which is the brunt of our patients coming from the tri-state area, vast majority, almost 2/3, consisted of our ovarian cancer patients. Only 22% of them were uterine and minuscule percent were cervix. So again, when we're thinking about who are we offering trials to, where are they coming from, what type of trials, it became very clear. The patient closest to our hospitals are actually the more Black population, endometrial cancer patients. And then we realized we actually didn't have so many endometrial trials available for them. And all the trials that we were running were primarily ovary for the most part. They were drawing from patients outside of the city. And it really, was interesting just to say, hey, where are the needs? What gap do we have? And how have we tried to improve? Well, it's not easy to just open trials because you want to open trials. You have to see what trials actually are available, whether it's with the industry, whether energy consortia or otherwise, and other ways to be strategic. So for endometrial cancer, we realize, carcinosarcoma, uterine serous, clear cell, these are really aggressive cancers. They're cancers that more affect the minority racial populations. What we've been able to do is actually partner, actually opening more phase 1/1/2 trials at some of our other cancer centers at Pennsylvania Hospital, for example, rather than the primary HUP site. And because these are multi-disease site, they actually allow us to enroll patients more of these high-grade histologies. And while they are targeted, for CCNE1, PIK3A mutations, other mutations, they actually have opened the door and more opportunities for our endometrial patients who are right here near to us. So as we think about recruitment and as we have more targeted therapy trials, it's great in some ways, but it's actually even more difficult to enroll in other ways as well. And now more and more of all our trials are very specific, very targeted by what gene signature a tumor has. And so now we have an entourage of trials, and now the list is long. Now they're very targeted, and now you're trying to keep track of all of them. And how do we literally screen? How do we find patients and literally match them to these trials? So here we have realized we need more sort of AI help. We need medical records searchability, and we need to be able to do this where the doctor, the oncologist, is not the navigator. We realize if you depend on the physician, they are one of the biggest barriers to efficiency. They don't have the time. They don't remember the trials when there are 30 of them to think through. And instead, we got to have this pre-screening approach. So what we have been able to do, for example, we have been able to get our hands on all the somatic genomic testing data. So we partner very closely with Caris Company. They're an outside company that does somatic gene testing for tumors. And what we've been able to do is we have contracted with Caris, where we actually are able to get the data for all our Penn patients that got Caris testing and have their results in their entire genomic profile, have their results available to us. So our clinical trials unit can actually search through that database and look for patients who have each and every particular targeted mutation that we are interested in. So that's one thing we've been able to do in terms of how do we find these patients. We also have an internal Penn Center for Personalized Diagnostics, which is our internal somatic testing platform. And we're working with our basically IT folks to figure out how we can also make that a searchable database. And it's our clinical trials unit personnel who's doing this. And when we have this pre-screen method, they can both actively, proactively look for patients for various trials, as well as when patients are funneled in, they can more quickly do a screening method. So they are driving the ship, not the physician. But what's important, as we heard over and over again from some of our patients and ambassadors, is that the doctor must endorse that clinical trials are an opportunity and that this is a standard of care option, actually. So other things that we've done is, for example, when we think about how do we decentralize clinical trials, make the burden less, don't drag the patients in for every component of the trial and every visit. So here we were looking at whether incorporation of telehealth in clinical trials was feasible. And we looked at this from various perspectives, and this is where we published several studies out of this. One, we looked at a retrospective cohort study of patients who actually had, as part of their clinical trial experience in our unit, telemedicine care versus their control was involvement in the clinical trial before telemedicine kicked in. Now, granted, we know this was part due to the COVID pandemic. However, that being said, we were able to do this analysis of our research unit, all our patients enrolled at the time, pre and post tele. And what we ultimately found was that remote clinical trials operations, of course, increased, but it did not increase operational delays. The patient touch points, how many interaction with the patients were not more, meaning it didn't burden the unit. Adverse events did not increase. And while deviations increase, these were deviations that were related to sort of pauses, delays. They weren't ultimately, I would say, negatively impactful deviations to the clinical trials. So what we were able to publish and show from this is that incorporation telemedicine into clinical trials protocol was feasible. It was certainly effective, and we want to advocate for continued reimbursement for telemedicine care. So what we've also actually completed at this point is a qualitative study of regarding telehealth utilization in clinical trials that was published recently. And additionally, we did a cost study as well that was recently published that showed that implementation of telehealth in clinical trials operations did not per se increase the cost. So those are additional, I think, important things to consider where we want to use that information to advocate for innovation in clinical trial design. So what next? Incorporating supportive care resources into trial design and budgeting. What are supportive care resources, you might ask? So we're going to dive into this, all right? And this is where we think about social determinants of health. We think about truly addressing those barriers like financial concerns and transportation concerns, et cetera. So here, we've looked at practical barriers that are well published in the literature, but how do you actually do something about it? And so here we have published several commentaries, briefs, and also actually pilot programs that we've initiated. What we know, transportation services are definitely a barrier. 12 to 30% of cancer patients report that is a barrier. This is well published. There are some available services through Medicaid programs for non-emergency medical transports that actually provide services to 6 million patients in the US a year. Now, this is why we need funding for Medicaid. These are just realistic issues that patients have, whether they're cancer patients or non-cancer patients. And through these programs, they are able to partner with rideshare like Uber Health and Lyft. And at Penn, we also have been grateful for philanthropy and grant funding that has also supported transportation rideshare costs that we're able to then pass on to patients. And as part of this, we have incorporated into the clinical trial patient population. We want to, and we do offer this as a service. So what we have done, we've actually piloted and now implemented this rideshare program from 2022 to the present, where patients do complete social determinants of health screening intake through Epic EMR as a new patient or when they're enrolling in a clinical trial, and at least once a year there as well. If there's a flag for need, then they're navigated. Additionally, if patients just mention that they are in need of transportation assistance, talking to our nurse, our scheduler, our surgery coordinator, our clinical trial staff, we also route them to our transportation rideshare program. We have dedicated staff. We have figured out how to implement this at multiple sites. So it takes administrative coordination with our trials unit personnel to then actually arrange the transportation with the patient for the day, time that they need. There's a text messaging sort of communication or phone messaging communication with the patient. The patient gets a ride, they get to the site of treatment, they get their treatment, and they get a ride home. So some of the earlier data, initial 15 months, we did publish on 133 patients, needed or screen positive. We were able to provide 48 patients with rides. We found that they tend to be older, lived within our nearby hospitals. There tend to be minority patients, provided over 400 rides at about $25 each way. And it really did help those with mobility issues, and it also did help folks who were enrolled in clinical trials. Now let's look at financial toxicity, another barrier that's real. We conducted a study within our patient population of all our gyn-onc patients. Up to 50, it was about 50% reported they had some financial barrier concerns. So that is substantial, even for our Penn health system, where essentially every patient walking our door is insured or needs to be insured to get care. So in terms of, we want to be able to provide services and transparency and cost estimates. So we did initiate financial navigation pilot, was funded through the Foundation of Women's Cancer. So we wanted to, offer screening at clinical trial enrollment. This is also just standard of care offered to all patients, new patients coming in. And ultimately, we were able to refer 1 to 3 patients per month. Initially, we had a system set up where we were navigating to our financial counselors, our social workers, and able to help these patients figure out ways to address barriers of finances. Issue is, how do we sustain these efforts? It takes resources, person time, and costs. But for what it's worth, was it beneficial? We did some qualitative analyses that we just presented at SGO meeting, where we were able to interview patients, for example, that did participate in our financial navigation program. Some also received transportation. And, their quotes were really telling. One said, I know I have to get there. It's going to be a problem because I don't have any money to get there. I don't know how to get there. I don't have a friend with a car. I can't go on a bike, and walking is out of the question, right? Housing, they helped me pay a month of rent, which is a big relief for my family because my husband is also a cancer patient. So having to deal with special needs child, 2 cancer patients at home, it's a lot of stress. Food, I struggled with my bills, paying my bills because I was on disability. It took forever. Talked about food insecurity because I couldn't fill my fridge, couldn't afford it. Employment, due to treatment, I did go on disability, but I did return my job within a month and change. I had to get a second job because the cost of everything is just so high. I can't make ends meet. And navigating, somebody can help you understand the language, because there's a language to forms that you have to fill out, things that you have to sign. It's just so difficult. I don't think any of us would find this to be surprising, but it really highlights the need. And so over time, you might ask, well, how far have we gotten, after several years of effort and for supportive care, delivery of care? Well, this was sort of a more of a analytic analysis over several years, 2 years time worth, and recently was presented at SGO. So in this time frame, over 6,000 patients are seen in our health system, and about over 200 receive various types of supportive care services, transportation, financial, et cetera, peer support. About a third of them found their way through the S2H screening instrument. Others were just navigated through usual care. And as of February 2025, specifically regarding transportation, we have provided over 2,600 rides that cost about $29 per ride, total cost of $74,000 that we had to actually support, and this largely came through philanthropy. But when we look at patient populations, who are we really serving? Where are they coming from? How they differ? And it was actually really interesting. Our financial navigation patients were actually more privately insured patients, and they were actually more patients who were actually still working. And those that largely needed transportation are actually more our retired patients, more of our patients right here in our metropolitan Philly area, more of them that were minority patients. So, it just really starts to shed light about who needs what services and how do you better target your interventions. And then we looked at what was the healthcare utilization, right? Because from a high level administrative standpoint, we do think about where are our unplanned admissions, where are our ED visits coming from? Is it at all related to the patients who might have more barriers to care? Overall, healthcare utilization was really high. These patients with cancer, have a lot of visits. Of all these SCP patients, they had 11 to 13 visits after their engagement in our SCP program, and then a lot of unplanned ED admissions, as well as our ED visits and admissions that you could see here, 115, 152 ED visits during this time frame, and they were higher in our transportation group than financial. And what we're doing as an ongoing effort is looking at not just utilization, but we're going to layer on cost data. We're also going to do mixed methods analyses. Ultimately, we're really trying to say, hey, for all this effort, all the resources, all the services delivered, what have we had to invest? What was our return? What was the benefit to the patient? So the last phase of it, I'm going to just move through sort of the community engagement part. And this here is truly important. Ultimately, you want to try to engage patients, have patients be part of the design of how you're building the program, rather than just think about them as people to enroll at the end of the day. And if we can do that, I think ultimately we'll have better design, we'll have better program structure, and there'll be a lot more return to the community. And there are different ways to measure how you have engaged these patients. What's the snowballing effect when you've started with one person and then the next person, next organization as you roll it out? How many have you engaged? What are the sort of populations you've engaged in various forms? And you can try to measure these as you go. And this is a piece that's definitely a work in progress. I'd say this is the piece that's the least developed at this point for us, where we're actually starting to just get into the community centers, the different senior centers, the different community health centers, and doing outreach. And it's not really just for clinical trials. It's honestly for gynonc in general, because the reality is most people don't realize that bleeding irregularly, well into your 50s and 60s is absolutely not normal. They don't realize per se what are the signs and symptoms of gynecologic cancers. And recently we had gone to a senior community center, done just a engagement talk. And it was really interesting. This was a mixed audience, men and women. And what came out really that was that talking about, even patient, family members of cancer, GYN cancer, was just very, very shameful. And that the diagnoses were just absolutely being kept quiet. And this was just one of the most telling things. This is why GYN cancer care and knowledge is still, I'd say, so far behind. So as we think about socialization and talking about clinical trials to patients, what do we need to do? As a provider, we got to plant the seed early. You can't talk about trials when they're just entering their third line. Has to be mentioned with the initial treatment visits. Engage your entire care team, navigators, APPs, social workers, nurses. Involve lay advocates if you can. I can't say that we've necessarily done this yet, but if you can, it'd be great. Think about how you can put it out there on social media. Of course, we have to be cognizant with what goes out on media these days, but when you are able, how can you do it in ways that are interactive, live media, and then how can you get into the community, giving talks at local events, giving talks at patient advocacy conferences, for example. We think about talking at SGO, but that's not where patients go to hear things. They go to their conferences, which are totally different set of conferences. So we got to think about where we're actually putting it out. And then when you talk, what does a patient want to hear? I thought this was really telling. And this is from a national prostate cancer advocate, a patient. And this is what they shared. You must talk their language. When you say clinical trials, they might think Tuskegee. You got to talk to them like they're a family member, like a human being. because they're already scared. You want to be authentic, real, not tell them, if you participate, we'll give you $20. And how does it benefit me? What are you going to tell me after the study is done? What does it do for me? When the study ends, don't forget about me. Don't just make a database and like as if you used us. Not all people have iPhones either. Some of us still got flip phones. All you can do is turn it on and off. And you might not like technology when you're a certain age. And wording is important. Don't say, I know what you're going through when you haven't been through it. Clinical trials, however, can be the best drugs. And, maybe I didn't think to ask, is there a clinical trial available instead of just taking out part of my lung? Maybe that would have been a better option. Know where they're coming from and really have a navigator patient experience in cancer who can accompany the patient in clinic. So rounding out the end of the talk here, as we think about how do we communicate with patients, maybe it's not the provider. Here, I had basically designed and conducted a patient-based ambassador discussion program. So it's a peer-to-peer. And here we wanted to really engage a patient who had been through a clinical trial and had experience with it to serve as ambassador, talk to other patients. And so this is a study that I had conducted to determine feasibility, acceptability. How do we do this? And what we did, we were able to engage 3 patients who were clinical trial participants within our gyn-onc group. We trained them up. We designed a curriculum about clinical trials. And then we supported them as we then found mentees for them, patients who had advanced recurrent cancer, never been a trial participant, but maybe could be interested in hearing about it. What is a trial? And so we did all these chats on Zooms where the ambassadors met with patients. We did 20 pairings, 20 dyads. And ultimately, as we went through this peer-to-peer discussion program, we then collected outcomes. So we did pre-chat assessments, we did post-chat assessments, including clinical trials knowledge surveys. We looked at our implementation processes. We also had metrics such as feasibility, acceptability, and net promoter score. As a participant patient, would you want this program to continue? What are your suggestions for improving them? We also did sort of exit interviews and mid-program interviews with ambassadors. What was difficult for participating as ambassador? What would you think would work better in the future? And, for what it's worth, this will be presented at ASCO coming up in June. We completed the project. We have collected a variety types of metrics and feedback. And for the short version, we do think there's a lot of feasibility to expand this further. Lastly, last couple slides here, are there ways we can cover, the cost of care coordination? I wanted to highlight from just a practice standpoint, there are some CPT codes that we can use and potentially get reimbursed for especially complex disease treatment planning, which very well could include clinical trials, discussion, enrollment, access, navigation. So I just wanted to share those. In terms of billing for clinical trials participation, while you don't get reimbursed for these, if you use these codes, then it does indicate that the patient's encounter was associated with clinical trials participation as they're listed here. And lastly, how do we advocate and engage in a shared mission? I think as individuals, individual constituents of our states, we all can take part. And for example, if you wanted, you could take part in an organization fashion, whether it's for ACOG or SGO. We have fly-in days annually. We have ambassadors, which could be even medical students or college, residents, fellows, attendings participate in advocacy work. And why does it make a difference? We take for granted that insurance covers clinical trial costs. And in fact, it was not until 2022 that Medicaid actually covered this uniformly. And this was passed by the Clinical Trials Act in 2022. It was passed because of a huge advocacy effort from many medical organizations that this is important. Previously, 38 states in the US did not have clinical trials coverage by Medicaid. So if we want to enroll patients and we want insurance to help cover just their basic medical costs of participation, these are the type of policy efforts that need to be passed and engaged in. Now, what about now? Telehealth, we talked about decentralization. Well, keep in mind that reimbursement telehealth basically expired this March, and it was not for just the continuing resolution that was just passed recently a month ago that they extended reimbursement for telehealth to December of 2025. This is something that will have to be advocated for from from all of us as constituents and as policy proponents. Otherwise, we cannot sit here and assume that we will get reimbursed for telemedicine coverage, whether it's for standard of care or whether it's for clinical trials in the years to come. And lastly, call to action, as we can see here, we do know that research funding is in jeopardy, and it's not just in jeopardy, it is being cut. That's absolute. And that's been very recently in the last couple months. The Department of Defense research program funding has been cut by 57%. Fortunately for the ovarian cancer portion of it, we've been able to preserve the majority of all this funding here. However, this is drastic. And NIH actually has been cut hugely as well. And this just came out within the last week. Why does it matter? Well, because of programs like the ovarian cancer program, Department of Defense research funding, over the past couple decades, 132 patent applications for ovarian cancer treatment have been put forth. 2,000 plus publications related to ovarian cancer have been put forth. And this is because there were these resources and there's research funding to support it. So where we can take, participate if we were interested, these are ways. And if you see emails come through ACOG or SGO or other sources where there really is call to action, take 5 seconds, consider it, to take that action. So this is, I think, a very broad sweep of all the efforts we have made to increase participation and access for clinical trials in our group. And here highlighted themes that we talked about and many of the steps that we took. And it's been a pleasure to be able to speak to all of you. I'm extremely grateful for all the various funding sources and the many members that have participated in all this work. And I will open up to questions.
Thank you so much, Dr. Ko. I see we have a hand up. Go ahead.
Hi, thank you for an absolutely fantastic talk. Very quickly, can you expand a little bit about, you mentioned as an alternative to your TPC program, you had folks screening. Are those GYN specific, like CTS? Is that nursing? What format is that? Who are those folks that are in that cohort?
Yeah, so the actual people who are doing the screening are staff in our clinical trials unit. So they're actually our research coordinators in our unit that are actually doing the screening. And what we're doing, we're funneling, we have an Epic shared list. So any patient that is basically recurrent or needs to be considered, like just say, hey, third line, oh, need a new therapy, right? Ovarian cancer. As a provider, I don't have the burden to say I have to figure out which trial. I can send their name in, and then a member of our unit will then just look through our roster of trials open at multiple cancer centers and try to pre-screen, which ones they might be available for.
Thank you.
Go ahead, Dr. Rosenfeld.
Good morning. Thank you so much for a wonderful presentation. I am one of the MFM faculty, and I actually used to be a clinical research coordinator in a prior life, and this will age me, but I remember when UCSF went from paper charts to Epic and the excitement as a coordinator being able to pre-screen patients. My question for you is how you deal with consenting patients that are non-English speaking. I'm lucky to have research coordinators who are fluent in Spanish, but that still leaves a number of patients that do not speak a native language that either myself or my coordinators speak. How do you deal with making sure that we're communicating the risks of trials appropriately, especially in the MFM setting where there's a fetus involved, and using those like IRB short forms?
Yeah, that's a great question. I think I wish that we could do even better, honestly. You know, we use our research unit certainly uses the hospital-based, hospital translator services, right? And certainly there are, a couple of folks in there that speak a few other languages, right? So that's helpful. And we definitely use the short forms as much as possible. And for, we have to, for each trial, we have to go through the legwork of, can we enroll patients of this language. And one trial recently, it was a little bit sad. It was a patient who didn't primarily speak English, and because they used a telephone, like a texting check-in, we went all the way up to the sponsor, and they said at the end of the day, sorry, we just can't enroll your patient because they weren't a native English speaker. And we're like, what if their family member, helps them with that? And they're like, no. So I think we try to do our best. But like you pointed out, I think it's still not enough.
Alrighty, thank you so much. Unfortunately, we are out of time. It is 9 a.m. So I just wanted to let everyone know and say thank you so much to our speaker for today. And also just wanted to, we'll let you know that we will be seeing you all next Friday for our grand rounds. And so we'll just have to wrap up here.
Great. Thank you so much.
Yeah, you're on.
Thank you.